Dear doctors, welcome to EasyMed. Today we will discuss about genital tuberculosis. This is also called FGTB when caused in females. We will primarily focus on FGTB only. So now here you can see a laparoscopic view of the genital tract. You can see the uterus, the fallopian tubes, and you can see the contour of the organs here, the condition. So this is a laparoscopic this is a laparoscopic view. The findings which you will find, primarily you will see that this is ulcerative. Here you can see ulcerative, everywhere there is ulcer. So ulcerative in most of the cases, maximum. But in some cases you will also find papillomatous form and miliary form as well, Now when we talk about genital tuberculosis, okay, so the causative agent is obviously Mycobacterium tuberculosis. Mycobacterium tuberculosis. And the primary infection which happens, in most of the cases, the primary infection is where? Yes, in the lungs. And from the lungs there is spread. Apart from that, primary infection might be also found in urinary tract, in the bones, etc. And in the genital tract, secondary to these sites, infection secondary to these sites happen. Now, in this genital tract, in this FGTB, in this case, the primary site is the fallopian tubes, and plus minus endometrium. So when a patient comes to you with genital tuberculosis, the primary site where you will find these kind of findings, this will be the fallopian tube and the endometrium, primary affected site, and this will be in 50 to 60% of the cases. Now if we talk about spread of the infection, spread might be hematogenous, that is through blood, lymphatics, through the lymphatics. Spread might be direct as well, and it can be ascending. But ascending is rare, very, very rare. This is very rare. Let's discuss the pathology. So in pathology, we have to appreciate that the most common site of infection, as we have already discussed, is the fallopian tubes. And endometrium as well, plus minus endometrium. Now the infection, this infection basically moves along the wall of the uterus and destroys the fibrous tissue. So infection moves along wall of uterus, and so there is fibrous tissue. There we have the fibrous tissue, and this infection destroys the fibrous tissue. The typical finding which you will find here is, the typical finding will be tobacco pouch appearance of the abdominal ostium. Abdominal ostium will have a tobacco pouch appearance. Will have a tobacco pouch appearance. Now what happens actually? So there is formation of tubercles. Now when this tubercles burst open, the caseous fluid pours down inside the lumen. So when it pours down inside the lumen, we have different pathologies coming out, like tubercular pyosalpinx. So let's write it like this. There is tubercle bursts. The tubercle bursts open. It bursts. So when it bursts, two incidences might happen. One is, okay, so you have here the caseous fluid, fluid. Now when it bursts open, two incidences might happen. The caseous fluid might fall inside the lumen excuse me, or outside the lumen. So inside lumen or outside lumen. This is false. If it falls inside the lumen, there will be tubercular pyosalpinx. And if it falls outside the lumen, that is, there is outward spread, there will be perisalpingitis or exudation. Exudation is in most of the cases accompanied with perisalpingitis. More findings might be tubo-ovarian mass, and miliary tubercles, but rarely, as we have discussed already, that miliary is very rare. Now, speaking about involvement, 60% of the cases are with endometrial involvement. Endometrial involvement. And ovary. 30% of the cases with tubercular salpingitis. Very important to remember here is 40 to 50% of the cases, in 40 to 50% of the cases you can find pelvic peritonitis. Either wet or dry form. What is the histology now? The histology. You will find granuloma, with Langerhans cells giving infiltration, making an infiltration. You will find inflamed cells and epithelioid cells. Now let's come to clinical features. Clinical features. Mostly it is found in 20 to 40 years of age, individuals of 20 to 40 years in age. And (20 to 40% of patients of lung TB. Symptoms. Symptoms might be infertility, weakness, fever, anorexia, anemia. Now with all these things, anorexia is little typical here. Apart from that, all these things are very common. Apart from anorexia and infertility. Apart from that, what you will have is menstrual abnormality. In 50% of the cases. Now this abnormality can be menorrhagia or oligo or amenorrhea. This can be menorrhagia or oligo or amenorrhea. And there might be present vaginal bleeding postcoital. Let's talk about some signs of FGTB. Health. Average health of the patient is satisfactory. It is very satisfactory and not much affected. But when we do per abdomen examination, per abdomen, we feel duft. The feeling on palpation is duft due to matted intestine, matted intestine. And on per vaginum examination, we can find vulvar or vaginal ulcer. We can find tube thickening, and we might feel bilateral pelvic mass. So, investigations. Now let's talk about the investigations. What investigations are to be performed in cases of FGTB? We will perform a CBC, complete blood count, and what we will see there, naturally you can guess, we will see that WBC is increased, that is leukocytosis. We will see high ESR, and then we will also do MON2 test. We will also do MON2 test, which depends on specificity. This will be positive. We should do a chest X-ray, CXR or chest X-ray, and we can visualize pulmonary lesion. We can visualize pulmonary lesion, and we should do a D and C, that is dilatation and curettage, and collect two samples. Now one sample, now both the samples should be in normal saline, but one should be sent for histology, and one for culturing. In histology, you will typically detect giant cells. And false negative result is very high. And on culture, you will do the culture in Lowenstein-Jensen media. You can identify an acid-fast bacilli on Ziehl-Neelsen stain or by guinea pig inoculation. But you should remember that a clinician should not wait for all these. A clinician should not wait for all these culture and things, because it takes time. It is time consuming, and you should start the therapy. So with these tests, an additional immunospecific assay is available for tuberculosis, which is called IGRA. which is called IGRA. Now at some times, I have myself experienced it. Sometimes there is negative result in the Monteau test. There is negative result in the Monteau test, but all the findings like the CXR, the CBC, all the findings are suggestive of tuberculosis. So basically that is a false negative result. So then you should go for IGRA, and if the IGRA gives you a positive result, always remember there is TB. If both of these are positive result, you are 200% confirmed that it is TB. And this IGRA, I am not only speaking about genital tuberculosis, but in cases of all tuberculosis. So very important is IGRA. Now apart from these, you can, for detection purpose, you can do liquid culture in automated bacteria, which takes around 9 to 10 days. This is also a long process. Fast process always is the RT-PCR. You go for an RT-PCR. That is 85 to 90% sensitive. And you can also go for an automated SIBNAT. This is 2 hours. You can get this result in 2 hours. Now this RT-PCR, where will you take the sample from? The sample should be taken from first menstrual blood. The first menstrual blood. Now we will discuss about the treatment. The treatment. So treatment, you can divide it into two: general treatment and chemotherapy. Now general treatment, if lungs are not involved, then there is no need for hospitalization. No need for hospitalization. You will simply perform diet correction. Raise the immunity. Treatment of the anemia. Anemia is to be treated. And you suggest the person, if the woman, if her sexual life has already started, you suggest her to use condom. Then chemotherapy. Now basically in chemotherapy, so we have drugs, we have drug regimes in chemotherapy, and we divide it into two depending on the cases, on the case history. If it is a new case, then we go for the formula 2HRZE for 2 months, or we can go for 4HRE for 4 months. Not or, actually it's plus. First 2 months of 2HRZE and then next 4 months of HRE. Okay, then relapsed cases. if these are relapsed cases, we will go for two HRZE for 2 months and 4 HRE for 4 months. Now what's the difference is, sometimes in the relapsed cases we can modify this HRE regime depending on the observation. Now what is this HRZE or HRE? What is this? So let's write here HRZE. This is isoniazid. R is rifampicin. Z is pyrazanamide. And E is ethambutol. This is the general regimen for therapy management or therapeutical management of genital tuberculosis, but sometimes depending on the cases the doctors might go for other therapeutic regimes as per their clinical choice. They might use streptomycin and other antibacterial spectrum drugs like this. Now surgery. So indication for surgery in this case is like if there is absolute destruction of the genital organs, so you might opt for a surgery. And if the woman has already completed her family, so you might then think about surgery or go for a surgery. So surgery here you will perform, what you will perform is radical hysterectomy, with bilateral salpingo-oophorectomy. This salpingo-oophorectomy, just conveying you this salpingo-oophorectomy is often also called adnexectomy. So we have discussed completely about genital tuberculosis today. Please do support our channel, like the video, share it amongst your friends. Best of luck. Please like the video, comment on it, share it amongst your friends, subscribe to the channel, and don't forget to hit the bell icon.